Welcome, everybody, to today's session. We're going to give it a few minutes for people to join, and we will get started shortly. In the meanwhile, if you would like to introduce yourself in the chat, we'd love to hear and see who we have online joining us. So please share your name, organization, and where you're joining us from. I think we should get started. Welcome, everybody, to today's session on science integrity in sexual and reproductive health and rights. Navigating truth in a changing world. We are delighted to have so many of you with us today. We have over 600 people register, and we have close to 100 and more people joining online as we go. My name is Nandita Thatte. I'm the technical officer at WHO in the Department of Sexual and Reproductive Health and Research, where I also support HRP. In this role, I lead the IBP Network. We are a consortium of NGO and civil society organizations working to disseminate guidelines, research, and evidence, but also provide spaces like this to have difficult conversations and really advance the work of sexual and reproductive health and rights. So we are delighted to be co-hosting this with our colleagues at HRP and WHO today. We have a very full agenda. You can see it here. So I'm not going to spend too much time going through, but we are delighted to have a number of speakers with us to share their experience trying to understand and document misinformation, personal experience in challenging some of the misinformation, and then also some reflections from partners working on the ground in academia, offering some insights on how we can address this really important issue moving forward. Before we begin, just a little bit of housekeeping. We are recording today's session, and it will be available on the WHO HRP media channel on YouTube. Please do submit questions in the Q&A box or the chat. We might not have time at the end, but our speakers will try to keep on top of the questions and answer as they come in. And finally, for more information about this topic and the many other topics that we are tackling in the Department of SRHR, WHO, please visit HRP website or the IBP Network.org. Okay, so we wanted to do a little exercise just to get a little interactive. So we have a Slido on the screen. You should be able to join going to slido.com. And the question we're asking is, what concerns you most about the state of sexual and reproductive health in the current global health environment? So please submit your responses. You can answer multiple times, 1 or 2 words, whatever comes to mind. We'd love to just sort of hear what you all are feeling and thinking about where we are in this space. So we'll give it a few minutes. For those of you who are not familiar with Slido or the word cloud, as people mention the same word or phrase, the font gets bigger. And so we can see lots of responses around opposition, choices, rights, equity, opposition. Many of you are mentioning opposition, lack of body literacy, human rights violations. These are all topics that we are going to be tackling today and in the coming sessions. So we'll just give it a few more minutes, let people engage a little bit. I think we're getting sort of a clear idea to our panelists and participants online. Clearly, we're all struggling with some of these issues concerning SRHR, certainly opposition, misinformation, which we'll talk about today, backsliding, lack of equity, and many, many others. All right, I'm going to keep going. You can continue to sort of enter information as you like, but I think we're going to move to the first speaker. So for this first speaker, I would like to introduce my colleague, Dr. James Kiarie. He is the head of the Contraception and Fertility Care and Services Unit here at WHO Department of Sexual and Reproductive and HRP. So James, I'll pass the floor to you for some opening remarks. Welcome.
Yeah, thank you. Thank you, Nandita. And thank you to the organizers of the webinar for giving me this opportunity to make some opening remarks in this webinar. And I would like just to make 3 points quickly that I believe are very important for us to consider as we listen to the presentations today and as we also go into the discussion session. The first point is why now? We know that from time immemorial, sexual reproductive health and rights, particularly in areas of contraception, infertility, and abortion, has been plagued by misinformation, myths, and even outright falsehoods. And this either intentionally or unintentionally limit human rights and choices and often deepen inequalities. And the issue is not just academic, as the misinformation can result in disempowerment, ill health, and even increased mortality. But unfortunately, in today's age of digital technology and AI, the spread of misinformation has accelerated. And while science and evidence is often buried deep in the information noise, we find that misinformation is actually becoming more and more prominent. And this is why we must act, particularly during this time. My second point is why WHO and HRP. So we know that the World Health Organization is a normative body, and therefore it has a unique responsibility to uphold science and evidence, and also to make this evidence accessible. And even if you look at the theory of change of the Special Human Reproduction Program, HRP, that is hosted by WHO, which is where I work, the theory of change of HRP is grounded on a cascade of changes. And this cascade is generating evidence to strengthen health systems and therefore to impact lives. Therefore, we see that WHO's work and the HRP theory of change will obviously break down in the presence of widespread misinformation, myths, and falsehoods. And this is why actually last year in April 2024, our governing body for HRP encouraged HRP to intensify our work in countering sexual reproductive health and rights myths and disinformation, recognizing access to benefits of scientific progress as a matter of human rights. And this is the reason why for WHO and for HRP, this work is of utter importance. And I would like to hear what others are doing, to share what we are doing, and some of the strategies, how we can make the science and evidence more prominent as we counter misinformation and disinformation. The last point I would like to make is why all of us. We know that alone, none of us can effectively push back on misinformation. And success will really depend on a strong partnership of multilateral organizations like WHO, partnerships like HRP, governments, civil society, academics, politicians, private sector players, and communities. And therefore, it is important that we all partner together and work together to push back on misinformation, disinformation, and on myths. On these three comments, I would like to welcome all of you to this webinar on science integrity. And I really look forward to a dynamic session today and to continuing this conversation as we continue to push for equitable, evidence-based sexual reproductive health and rights for all. Thank you very much, and over back to you, Nandita.
Sure. Thank you, James, for your opening remarks and inspiring comments as always. Okay. Next, I'd like to introduce my colleague, also at WHO, Aasa Nihlen. She is the human rights expert and our human rights advisor here at WHO in the Department of Sexual and Reproductive Health and HR. So Aasa, I'll turn it over to you. Welcome.
Thank you, Nandita. Thank you, James, and so nice to see so many people at this event. Looking forward to hear from everyone here. So while James made 3 points in his opening remarks, I will in this brief intervention only make one, and this is one directly related to what came out of the word cloud earlier. So while we are here as stakeholders in health, the topic we are discussing today is about human rights, and I will elaborate. So access to credible and accurate information is integral to realizing sexual and reproductive health and rights. The ability to make informed decisions across the full spectrum of sexual and reproductive health, from the prevention of harmful practices to contraception, fertility, pregnancy, to lifelong sexual health and well-being, is fundamental not only to overall health, but to dignity, and it enables people to thrive into the future. It's a matter of health, but it's also a matter of rights. Access to evidence and science is also an important tool for promoting the rule of law, other human rights, and for building trust. And human rights standards are enshrined in international law, and governments have committed to implement these in their national context. And this is done in 3 ways. It's done through respecting people's rights and not violate these or interfere with people exercising their rights. It is done through protect people's rights through developing laws and regulations, and it is done through fulfill people's rights through building systems that enable this. On this slide, I've noted some of the most key rights, or the key human rights, that we are covering in the webinar today. Next slide, please, Nandita. So while there has been huge progress over the years, recent data show a backsliding in how governments decide to apply human rights frameworks. This slide shows some key indicators and trends relating to the human rights quality of democratic regimes. And the top 3 declining indicators over the last 10 years all relate to freedom of the media, both in terms of censorship and the safety of journalists, restrictions in academic freedom and expression, and shrinking civil space. So these are all indicators related to how we generate and disseminate information, including on sexual and reproductive health. Recent data from 28 different countries across the world show that scientists and peers are the most trusted to tell the truth about new innovations and technologies. So in this context, we assess that as scientists working on sexual and reproductive health in the international space, we have a clear role, and we would like to have conversations with all of you on how to best make use of it. As a first step, we decided to make an attempt to diagnose the problem. While we all know that misinformation on sexual and reproductive health and rights poses significant risks, we wanted to learn more about what types of human rights impact that has been documented in literature, and what recommendations stakeholders in our field are proposing as solutions to address this. So, and with this, I will hand back the floor to Nandita to introduce my colleague Tina, who has led on this research, and to tell us more about its findings and their implications for advancing this as a dedicated area of work. Back to you, Nandita, and thank you.
Thanks, Aasa. Wonderful. As also mentioned, I'd like to now introduce our first speaker, Tina D Purnat from Harvard T. Chan School of Public Health. She's a doctor of public health candidate and has been doing a review of some of the misinformation in digital spaces in SRHR. So Tina, I will hand it over to you. Welcome.
Thank you very much. So we can go to the first slide, please. Great. So thank you very much. I'll be doing this presentation, as also mentioned, on behalf of the group of researchers that's been working with me and also has been steered and with lots of good input from also and the colleagues in HRP. And as you heard, the reason why we undertook this project was because misinformation about sexual and reproductive health and doesn't just affect individual choices, and it really undermines fundamental human rights principles and different systems that are there to support them. So let's go to the next slide. We have worked to do a scoping review, both of academic and grey literature, to review how misinformation about sexual and reproductive health in digital spaces is affecting human health and human rights. We looked at literature over the last 5 years, and even though the review had a focus on English sources, we captured a lot of discussions and examples covering over 40 countries and different global trends. So the report, the paper reporting the results is in final stages of preparation, but I will speak of only some key reflections today, and I think the rest of the webinar is going to go into a lot more detailed examples. Next slide, please. So when we talk about misinformation, we often think about some outrageous video or social media posts that a friend shared with us. But our review found that when we speak about misinformation, it can actually be described in many different ways, and it can mean many different things. So this word cloud on the left that you see shows all the different permutations and related words that were used in the articles and studies in our review. Now, the bottom line here is that the issue with misinformation isn't just about pieces of content or even narratives that are most common about sexual and reproductive health. It's more about our relationship with information, how we search for it, how we understand it, how we use it, how it's colored by our values and identities and the social context. So we can take a more systems level lens to the problems of sexual reproductive health misinformation when we apply a human rights lens to our thinking. And through this approach, we can then understand the structures, the drivers, and the power imbalances that drive sexual reproductive health misinformation and its harms. Next slide, please. So when people think of misinformation, they often think of social media, and instead of our entire information ecosystem and our personalized experience of information and relationships in digital spaces. And just like peeling an onion, if you pull back the layer of the information element you see here in red, you will find the other layers of impact with the individual at the center. Now, all of layers of this onion are affected by the misinformation and experience different impacts and drivers of harm within each layer. And we as humans, we have different activities and relationships. We move between these layers of influence every day, and we feel impacts on our daily life through all of them. So we summarized here on the right the top level impacts on sexual reproductive health, human rights principles across the different levels. And you'll see them here all affected in one way or another, from distortions in public discussion and perceptions through impacting legal and policymaking systems and how healthcare is delivered. Misinformation also impacts community networks and community norms, which then impact individual health decisions and can discourage care seeking. Now, if we see then that we need to go, think beyond individual content and narratives, and we are seeking seeing structural harms from misinformation, then then we need to ask ourselves, well, how do we need to pivot our thinking and approaches and to add to them beyond what we've been doing until now? So, which has focused on awareness raising, education, service improvement, advocacy, accountability, just a few things. And we need to ask ourselves, well, how do we add to existing coalitions and partnerships and approaches as we strengthen these systems, which are meant to protect these human rights principles? And I'll spend the rest of the time giving you some examples. So there are, next slide, please. There are increased concerns about the popularity, for example, of fertility trackers and menstrual cycle tracking apps that are affecting women's perceptions and behavior as it relates to their reproductive and contraceptive decisions. And the point I'm trying to make here is that this is a multi-layered issue that isn't just about the use of technology. One challenge, for example, is that individuals use the apps to obtain more information and make health decisions. But most of the apps don't reference sources of evidence and do not accurately portray the risk to users due to unreliability of their algorithms. And then there's the second issue, how these apps are a complement or a substitute or perceived substitute for health services or products. For example, it's been shown that usage of menstrual cycle apps is driven by mistrust in hormonal contraception in the UK. But on the other hand, in Brazil, women use them because of limited access to services and contraceptives. Then, for example, third challenge is that healthcare workers don't trust the predictions in these apps, but at the same time, they lack the skills and knowledge to assess the app credibility and reliability. So, we need to do better in supporting health workers and speaking to their clients about the mobile apps and how to assess their quality. But we need to do as much also better protecting users of the apps from misrepresentations. And then the fourth issue linked to mobile apps is that users are worried about how their private data might be tracked and could be used to target them for advertising or even used against them when there are legal restrictions on reproductive healthcare. So like I said earlier, how we identify the impacts and context of the usage of the apps then can inform a more multi-layered approach to how we address them. Next slide, please. What also came very strongly from our review is that information seeking is gendered. The majority of papers that we included in the review were about women's health or specific populations like LGBTQ communities or youth. But there's a lot less research on how sexual reproductive health misinformation impacts men. What's clear, though, is that how people seek information online and the type of questions and needs they have is gendered. And profiteers online have adapted very well to these patterns and needs. They'll serve up ads and deceptive websites and sell unproven and unnecessary treatments, services, and products that exploit people's beliefs, values, and identities. So you'll see here, for example, that non-evidence-based women's health products are lucrative business under the flag of girl power. And then there's really plenty of men's health clinics that do this type of direct-to-consumer marketing for dubious treatments for men. And there's different things that we could do, from improving digital literacy and thinking about, well, if we are trying to divert people away from using non-evidence-based products that might be promising quick fixes in ways that people feel more comfortable, well, then we also need to be much better delivering services and support in non-judgmental ways that people want, and also in digital context. So delivering better quality services and products also means having better consumer protections in place against deceptive marketing. And the way that I think about it and the way that I explain this is that, doctors who cause harm to their patients can be barred from medical practice, but there's really no equivalent standards to which wellness influencers are held to, even though they may be providing misleading medical advice. And there are fewer consumer protections regarding this on your phone than there are in your healthcare provider's office. Next slide, please. The other example that I wanted to show you is that, generally speaking, in health, health workers are the most trusted source of health information for people. And so they are one of the strongest allies in discussing and explaining health information with people and in communities. But younger generations have more information at their fingertips that their parents had before, from sources that they also find credible. And that means that healthcare workers no longer have a monopoly on providing health guidance, because people on TikTok can provide it as well, and there's no medical qualifications required for that. So in fact, studies have consistently shown that YouTube videos on specific social topics presented by health workers are far less popular and effective than videos on the same topics by influencers with no health credentials. And the evidence is in the packaging, because influencers tell a more compelling story and they can engage their minds and their audience about what they advocate for. They can actually change their mind for what they can what they advocate for at any one time. So younger generations don't automatically attribute authority to healthcare providers, and this adds the complexity of not only how communications is done in digital spaces, but also what we're asking healthcare workers to do and what support we're providing for them. So, for example, we're asking healthcare workers to do more, go online, be present and participate in discussions online. And we're asking them to be more exposed online, but we haven't taken systemic actions to support them. And we're just adding to their workload a lot of times, and this is outside of their general job descriptions. Next slide, please. The last example I wanted to show is the complexity over access to sexual reproductive health information. Most recently, in the US and several African countries, it's been documented that misinformation on sexual reproductive health is being codified into policies through law and strategic litigation. Now, when this happens and certain statements and assumptions are codified in law or in lawsuits, these are then used to legitimize misinformation and help amplify it further via social media. And this dynamic is reported happening actively across borders through purposeful actions in influencing policy and legal actions. And at the same time, we're seeing disparities in how internet platforms facilitate or restrict access to credible sexual reproductive health information in digital, in different countries and in different languages. Now, both of these forces can shape online spaces and the quality of digital information about sexual reproductive health in different regions, in different countries. And the absence of information, we need to think about it that the absence of information is just as harmful as the presence of misinformation. And both can be mitigated by addressing information voids. So it's really important to create plenty of opportunities for people to ask questions and discuss them and offer ample sexual reproductive health information where and when people need it. So doing this well isn't just about flooding social media. And next slide. This is the last slide. So, I mentioned that the paper discussing the results of the scoping review is in final stages of preparation. A detailed discussion would require a few extra hours. But to conclude, I would say that the big takeaway is that misinformation about sexual reproductive health and rights is a reflection of systemic asymmetries in seeking access to health information and care, and all of the systems supporting this. So improving access to health information and care and the supporting systems will mitigate the harms of misinformation. But we need to make sure that human rights lens is used when we think about how we strengthen systems that facilitate this. The way that I explain it is simply chasing specific misinformation narratives is not an effective way of dealing with a systemic phenomenon and a complex phenomenon, because sexual reproductive health is so closely tied to an individual, to community norms, to social identities and values. It will always demand systemic and people-centered solutions, and these would require, just like James mentioned earlier, and also new partnerships, new coalitions, better consumer protections, healthier digital spaces, where accurate information is freely available and discussed, and also healthcare providers and health systems that are better equipped to deal with this inevitable impact of the information ecosystem on their patients and their clients. So, complex problems are those where no one individual organization alone can address it. So we need to keep evolving our approaches and coalitions to match the pace of change in digital business and society. So I'll stop here. Thank you very much. Over to you.
Thank you, Tina. That was excellent and provided a really nice overview of what we're finding and actually sets us up nicely for the next presentation, which is from Dr. Chelsea Polis from Johns Hopkins School of Public Health. She's a reproductive health epidemiologist in New York City, and will be sharing some of her experience dealing directly with misinformation and addressing some of the issues that you highlighted, Tina. So Chelsea, welcome. Very happy to have you here. The floor is yours.
Thank you so much, Nandita, and thank you to the organizers, my co-panelists, and everybody who's joined today. I'm very glad to be able to think and talk together about how we can collectively protect scientific integrity in sexual and reproductive health, including in the face of mis and disinformation. Next slide. Misleading information exists in many types of locations, and it will require varied approaches to comprehensively address, as we just heard. Today, I'm going to focus my comments on one very specific location, scientific journals, where we generally anticipate finding trustworthy information. In my view, the evidence-based community has not yet sufficiently grappled with addressing misleading information in scientific journals, and concerningly, this can be weaponized to serve commercial or ideological interests. Next slide. We must protect scientific integrity to protect people. Publications in scientific journals can have substantial impact on policies and programs, and so can profoundly impact people's lives. Unfortunately, misleading publications are not uncommon, particularly when peer review is less rigorous. Concerningly, once misleading papers are published, it can be extremely difficult to correct the record, since authors, journals, and publishers have substantial disincentives to retract papers, even if they're dangerously flawed. And even when retractions do occur, they may take unacceptably long and cause harm in the interim. So we can think about an example of the paper which misleadingly linked MMR vaccines to autism. This took 12 years to retract from Lancet. The non-evidence-based views that took hold during that time may never be able to be fully rolled back, and we're paying for it now as we see low MMR uptake and measles outbreaks. Next slide. The global sexual and reproductive health landscape is changing with astonishing speed right now. Myths and misperceptions abound, and the rise of digital spaces and some political agendas can pose additional threats to clear, unbiased information on key sexual and reproductive health topics. This threatens the public's ability to exercise informed consent and achieve reproductive autonomy. We need people willing to work to protect scientific integrity, but as myself and others have learned, efforts to do so are often unfunded, rarely rewarded, and sometimes dangerous legally or otherwise. Next slide. Daisy is a $330 fertility thermometer manufactured by Valley Electronics and sold in over 35 countries. Users input menstrual cycle start dates and take their daily basal body temperature. An algorithm then attempts to predict which days each month the user is most fertile. Daisy is forbidden by the United States Food and Drug Administration to be sold as a contraceptive method, since it has not undergone the appropriate clinical studies or regulatory approval. It is permitted to be sold for use in trying to become pregnant, and this is an indication that has far less regulatory oversight. Next slide. Unfortunately, Valley Electronics has a long history of defying FDA regulations and hyping products in evidence-free ways. So in 2016, they wrote on Twitter, "Did you know that FDA blocks us from calling Daisy birth control or contraception? But she's 99.3% effective, thanks birth control." That estimate was based on a fatally flawed analysis published in 1998 on a predecessor device. Among other problems, their posts compared Daisy to copper IUDs, suggesting identical effectiveness. And I want to be very clear. I fully support people to use any contraceptive method that best fits with their values, lifestyles, and beliefs. And that includes fertility awareness-based methods, which is an area where I've done a lot of work to try to help clarify the evidence base. But as a contraceptive effectiveness expert, I know that a thermometer will never be as effective as an IUD. But not everybody knows this. Countless social media posts by the company spread this flawed information, putting people at risk of unintended pregnancy. Next slide. So in 2017, I privately and directly emailed Valley to ask if Daisy had ever been tested in a study with prospective measurement of pregnancies, which would be required to properly understand its contraceptive effectiveness. Their medical director responded to me saying that the costs and benefits of such a study are all out of proportion. A shocking statement which ignores the potential cost of an unplanned pregnancy to a user's reproductive autonomy. I suggested that they stop marketing the method as a contraceptive, alert users and potential customers that Daisy lacked sufficient evidence to be used as contraception, and instead focus on collecting high-quality data to adequately assess its true effectiveness. They said they'd raise my concerns to the board, but made no apparent changes. Next slide. A few months later, they published a fatally flawed paper claiming 99.4% contraceptive effectiveness. This was based on a retrospective mailed survey with a 13% response rate, which excluded most of the users at risk of pregnancy, and which was funded, analyzed, and co-authored by the company itself, which they inaccurately called an independent clinical trial, although it was neither independent nor a clinical trial. It contained egregious fatal flaws in both data collection and analysis. I detailed those flaws in a peer-reviewed commentary, which was published in the same journal, and we can share the link to that commentary in the chat if anybody's interested. My commentary requested retraction of their paper and better regulatory oversight of contraceptive claims. It was published in June of 2018, and the journal said their decision on whether to retract would occur in 1 week. The flawed paper was ultimately retracted after independent review confirmed my scientific concerns. However, that retraction didn't happen for over a year. During that time, Daisy misinformation spread all over social media, putting people, and especially young people, at risk of unintended pregnancy. The process of waiting and intermittently following up was time-consuming and frustrating. And speaking frankly, and I say this with radical honesty, full of hope for working together towards better solutions, I felt treated like a nuisance by some journal staff for trying to help preserve scientific integrity and the journal's reputation. And I've since learned that feeling treated with some disdain by journals is not uncommon for many research integrity practitioners. This must change if researchers and journals are to successfully work together to defend sound science. Next slide. The day my piece was published, I submitted an allegation of regulatory misconduct to the United States Food and Drug Administration. This prompted an FDA investigation, which eventually forced the company in 2019 to correct its marketing claims. So for example, they were made to remove the flawed study from their website, to contact customers that they believe relied on that study when deciding whether to buy a Daisy device, and to make other labeling changes to clarify that the device should not be used for contraception. These forced changes helped protect informed choice, reproductive autonomy, and public health, not only for existing Daisy users, but for anybody who is considering using the device. Next slide. After the retraction, I spoke with media, wrote explainers for non-scientific audiences, and engaged deeply with people in online fertility awareness groups. And I did these activities out of a sense of moral obligation, since these people most likely to be impacted, Daisy users or potential users, are not likely reading the back and forth in an academic journal, but they certainly deserve to have accurate information on which to base their personal choices. All of this work, done over many years, was done on unfunded personal time, which is unfortunately the case for so much research integrity work. Next slide. In media interviews, I used words like junk science to describe a retracted study and unethical to describe a company that had repeatedly violated FDA law. Valley claimed that such language was defamatory and filed a $1 million lawsuit against me, despite a journal and government agency having acted on my concerns. This is called a SLAP suit, which stands for Strategic Litigation Against Public Participation. These suits are often filed not with the intention of winning, but of financially and emotionally draining defendants until they give up. And in the United States, people defending evidence-based statements in court need to pay for legal counsel, even if the claims against them are ultimately not substantiated. Miraculously, an amazing team of lawyers led by Dory Hansworth at the firm Arnold & Porter took my case pro bono. After 2 years, Valley lost their lawsuit, including on appeal, but the process was excruciating for my family and I, took me away from funded work that could have helped consumers better navigate the confusing femtech landscape and more. Notably, this is not the only situation that I've observed when people whose work is critiqued on scientific methodological grounds resort to legal threats or action. I worry greatly about the chilling effect that these kinds of suits might have on other scientists or experts who may be reluctant to address flawed research out of fear. As a community, advocating for state and federal anti-SLAPP laws would be helpful to protect free speech on matters of public interest. Next slide. Valley published a new paper recently. Myself and other FABM experts are of the opinion that the analysis is once again egregiously flawed. It purports to produce the exact same estimate, 99.4%, as the retracted paper. In my opinion, this estimate was not calculated in a reliable manner. Also, instead of labeling this estimate as 99.4% contraceptive effectiveness, marketing now seems to refer to 99.4% accuracy for predicting the fertile window. I worry that this is a semantic difference, which may not help consumers understand that DZ's fertile window predictions have still not been tested nor received regulatory approval to be used for contraception. I worry that this information was published in a respected journal, and I worry that the sexual and reproductive health community has not collectively stepped up to help address these concerns. If we are to protect scientific integrity in sexual and reproductive health, we must each actively work to ensure that people have evidence-based information about any product they may use in pregnancy avoidance, and raising our voices as a community is most effective. Next slide. I'd like to share a few lessons I've learned. First, we must recognize that gaps and flaws exist in our peer review, regulatory, and legal systems, and we need to know what mechanisms can help address these flaws and gaps. We should also approach debates on these topics with humility and reflectiveness around how our community has allowed flawed information to flourish. And I have lots of thoughts on this with respect to fertility awareness-based methods that perhaps we can discuss later. Second, we must recognize that securing retractions of flawed papers can be time-consuming, demoralizing, legally risky, and nonetheless incredibly important to protecting scientific integrity and public health. In journals, failure to correct or retract unreliable research papers allows misleading information to spread under the journal's implicit approval. We must consider why this kind of corrective work is rarely funded and what funders can do to help make the ideal of science being self-corrective a reality. Next, actually not next slide. Sorry, same slide. Third, I hope people will learn about the variation in anti-SLAPP laws across jurisdictions and consider advocating for stronger such laws, as these would help people who are frivolously sued more quickly dispose of such cases. Fourth, researchers working on potentially litigious issues should ask their institution if and how they will support you if things go sideways. Organizations that champion scientific integrity should proactively think about if and how they can support their people doing this kind of work, be it emotionally, financially, via connections to lawyers, or in other ways. Fifth, we need legal networks that help researchers and journals speak as loudly as possible while avoiding frivolous legal threats or actions. This could range from offering document review to helping identify pro bono representation. What partnerships and collaborations could be formed to be able to more safely raise valid concerns without the threat of financial ruin? And finally, in the face of rampant and harmful mis- and disinformation in many domains, including sexual and reproductive health, it is our moral obligation not to throw up our hands and give up, but to be tenacious, to be bold, to find ways to actively support one another in protecting the integrity of the scientific literature and the ability of people, including legislators, to make informed and evidence-based decisions. We need to demystify science and ensure that we speak with communities in a way that builds trust. And each of us must ask what role we can individually play in combating misleading information, whether by speaking out ourselves or by actively supporting those who do. When we stand together, we make it harder for scientific integrity to be undermined. Next slide. Thank you very much for inviting me to join you today, and I'm really looking forward to the discussion.
Thank you so much, Chelsea. And I hope you can see from the comments and the participants online, really appreciating your work. Thank you also to Tina for setting the stage and really presenting a huge amount of work on sort of trying to identify the problem. So we've heard two very dynamic presentations. The first sort of showcasing the breadth and depth of this issue that we all face. And the second really what we can all do and what happens when we do try to challenge mis and disinformation in SRHR. and really the call to be a supportive community, engaging researchers, journals, communities, civil society, everyone has a stake in this issue. So I'm going to now turn it over to have a little bit of a discussion. Before I introduce our next speaker, for those online, I know many of you have questions. Please put your questions in the Q&A box, and we will try to answer them directly. I'll ask my colleagues Tina and Chelsea if you can respond directly, and if there's time at the end, we'll try to take a few. But I want to give some time to our discussants to really reflect on what we've heard from the presentations and what this means for work on the ground. So our first discussant is Innocent Grant. He's a former director at the Young and Alive initiative based in Tanzania, and is now at the Johns Hopkins School of Public Health and the co-chair of the International Conference on Family Planning Youth Subcommittee. So Innocent, you have the floor. Welcome.
Well, thank you so much, Nandita. I actually got chills when I was reading the article about Dr. Chelsea. So brave of doing that. But anyways, I wanted to share my reflection today when I was reflecting what I should present. I remembered in October 2023, I was invited for an interview with the BBC Swahili, and I was told the focus of this interview would be on family planning for sexually active adolescents and young adults. I was excited. This was a chance to share about the work we're doing in Tanzania, Young and Alive, but also the work that has sparked quite a number of conversations among people in Tanzania, especially because some of them still believe or are still asking me why a young man like me would be working in family planning, and something many assume that it's only for married couples. Now I arrived at the BBC studio in Dar es Salaam, and I was accompanied by my colleague Clara Mariwa, who we used to work together at Young and Alive, carrying with me one of my favorite resources, which is the WHO medical eligibility criteria for contraception and the WHO guideline for family planning provision for providers. My goal was to emphasize that family planning services are not just only evidence-based, but also they've been well packaged and resourced for providers offering contraceptive counseling. But to my surprise, it wasn't just like a debate when I arrived at the studio. It was just an interview, but it was rather a debate. And I was placed opposite the head of a major civil society, which is based in Kenya, who argued that teaching adolescents about family planning encourages them to engage in sex, and that such information does more harm than good. And in the heat of that debate, I was called names and pressured to agree with the perspective, but I stayed calm. I remember this became famous, this interview, because I asked only one simple question. What's very wrong if someone who is sexually active young person is going to have sex? But at least they've been informed. I emphasized what science says, that access to modern family planning helps prevent teenage pregnancy, reducing maternal mortality, and helps in improving the lives of people, contributing not only to the individual well-being, but also to the stronger economies of different countries. I underlined the importance of evidence-based information and reminded the audience of what happens when we ignore science. And we've actually seen this not so long ago during the COVID-19 in Tanzania, with the devastating impact of the science denial. I also took that moment to share some practical tools like the WHO medical eligibility criteria for contraception, the WIL, which is my favorite resource, and the family planning provider guideline that are freely available online and are grounded in decades of global evidence. But addressing misinformation, disinformation in Tanzania goes beyond just one media interview that I did with BBC, but it also demands we first acknowledge that misinformation, disinformation is a public health crisis. And unfortunately, this crisis isn't just fueled by social media influencers or political actors, but it's sometimes perpetuated by well-meaning professionals and even members of the public health community. As my colleague shares, sometimes you find these papers within scientific journals. Now, since 2017, I've worked with diverse groups in Tanzania to implement an intervention that recognize the limits of the digital literacy. We realized that the generalized family planning content often doesn't answer the specific questions that young people may have. So at Young and Alive, we did create a model called the Contraceptive Conversation Model, a community-based education session linked to an online platform, and an anonymous text line which uses where users can ask questions, receive timely, accurate, and use-centered response. Now, today, this model serves more than 10,000 users, not just in Tanzania, but also we realize it's also serving people from the neighboring countries like DRC and Kenya. Some of the questions that we receive may sound simple. For instance, can an implant travel to the heart? Do contraceptive pills fill in the stomach? One of the questions that still strikes in my mind is, can I use a condom twice? But they reflect really gaps in access to accurate sexual and reproductive health information. And if we don't respond quickly and truthful, others with misinformation, stigma, and fear are going to respond and keep spreading the misinformation. Now, I want to take this opportunity to give a big shout out to my colleagues, Dr. Matthias Kapenda, Dr. Anna Rose Ngere, and Dr. Abdul Swabu, who have volunteered tirelessly to answer these questions in our model. They are a generation that acts, a motive behind what I've now co-founded in Tanzania and in the African region in general called the Generation Act or Gen Act, a movement of generation that acts, leveraging the intergenerational collaboration, and everyone is welcome to join in. And we are focusing on knowledge management and private sector engagement. Now, the consequences of misinformation, disinformation, sexual and reproductive health and rights are not just abstract, but they are costing human lives today, somewhere, and in somehow. If we take one thing from this conversation today, let it be this: we must work collectively to understand the context that we operate in. And I'm going to say it again, we have to work together to understand the context that we do operate within our programs, and develop interventions that address the sources of misinformation, not just the symptoms of this misinformation. Let's not be afraid to speak the truth about what science says, even when it feels risky. As my colleague Chelsea Polis again shared in her Guardian interview, sometimes we become barriers to each other by saying, why bother? But we know for sure that our work matters. Now, because evidence matters, science matters, and most of all, people's lives and dignity matter as well. Now, I encourage all of us to here to continue contributing to the growing body of evidence around sexual and reproductive health and rights misinformation through documentation, through dialogues and research. One important opportunity is by submitting our programmatic experience and research abstracts to the coming International Conference of Family Planning 2025. Now, the deadline is approaching, and your voice, your data could help shape our global understanding and action. I'd like to end it there and give it back to you, Nandita. Thank you so much.
Wonderful. Thank you, Innocent, and thanks for sharing those experiences from the ground and the impact of misinformation. Also sharing how evidence-based tools coming out of WHO can help counter some of this misinformation in dialogues with communities and policymakers. Wonderful. So I'm now going to introduce our last discussant, Amanda Cordova Gomez from the Universidad Peruana Cayetano Heredia. Amanda she's a reproductive physiologist and global health expert, and we'll be sharing some reflections on how we can incorporate misinformation, identifying disinformation, science integrity into capacity strengthening activities. So Amanda, I'll turn it over to you. Welcome.
Thank you, Nandita. Thank you, everyone. So from the academic and research standpoint, it's clear false information, whether it's spread unknowingly or deliberately, has serious consequences. It damages health outcomes, reinforces harmful stigma, undermines policy efforts, and hits marginalized communities hardest. And while researchers and institutions are committed to advancing evidence-based solutions, we often lack a coordinated approach to directly confronting the spread of misinformation. And we are uniquely positioned to lead and support this space, but we need to be more intentional in doing so. Our responsibility isn't just to produce knowledge, but it's also to ensure that evidence is accessible, understandable, and usable by the communities and decision makers who need it the most. So as academic institutions, to strengthen research capacity and better response to misinformation, we can focus on different areas. I think, so one could be investing in identifying, monitoring misinformation and data infrastructure, which is That includes to be aware of common sources of misinformation, including predatory journals, pseudo scientific claims, scientific fraud, misleading journalism. Also recognize how misinformation is spread across digital platforms and through AI-generated content, as these are becoming increasingly common sources of misinformation or information in general. Learning how to identify which sources can be trusted is essential to distinguish between accurate and false information, expand monitoring efforts, and also adopt innovative data collection methods, including engaging social media users to gather insights and track emerging misinformation trends. We could also deepen our research on impact and pathways. So examine how misinformation shapes country-specific beliefs, behaviors, and health outcomes, as well as to investigate and understand the psychological and social mechanisms that make this misinformation stick. Tailor responses to community needs. Research should be inclusive and participatory, include community-based organizations and professional schools, for example, involve affected communities in research design to ensure relevance and impact, and evaluate what works, study which interventions are effective and in which contexts, understand potential and intended consequences like the trust erosion in science. And I think that one of the key areas for us researchers to strengthen scientific communication. Scientists are trained to be cautious, evidence-focused, and transparent about uncertainty, but these norms don't always translate well into public communication. In fact, it is a misconception to think that someone successful in research will also succeed in politics or policy making, in which the events move faster than academia. And the way of delivery is different. So we need to improve how to communicate science to non-expert audiences. And this alternative way of communicating science could include translated evidence into plain language, framing messages around shared values and lived experiences, tailoring outreach to specific audiences, and use alternative ways of communication beyond our known technical platforms and format. A strong communication is a core to research impact in today's information environment. It is also crucial to build a long-term research capacity, and this includes support early career researchers and practitioners in developing expertise on misinformation, including the use of AI-generated content and how to distinguish between false and accurate information. Invest in interdisciplinary training that bridges public health, communication, technology, and policy. And foster collaboration across institutions, countries, and sectors about knowledge. We need to protect the integrity of knowledge ecosystem. This is key. Misinformation doesn't just distort facts, but actually undermines trust in public institutions and evidence-based policy. And just a few closing remarks is that there is no single fix for misinformation. It will take a sustained systemic effort rooted in collaboration, trust, and shared responsibility. Academic institutions and researchers must be at the forefront, not just producing evidence, but also helping society and including policymakers to make sense of it. And also that by strengthening research capacity and reimagining how we engage with the public, we can build a more resilient health systems, protect rights, and support informed, empowered communities. Thank you.
Well, thank you, Amanda, for those reflections on the role of researchers, academics, not only in communicating research more effectively, but ensuring that research is informed by communities. And again, this theme of collaboration and really working together to address some of these issues. Wonderful. I'm now going to turn it over to my colleague, Tigest Tamrat, who's going to give us a little teaser about the next session that we are planning. So Tigest, let me turn it over to you really quickly. Tigest is a scientist here at WHO in the Department of Sexual and Reproductive Health Research, working on digital technologies. Tigest, you have the floor.
Great, thank you so much. And it's been really wonderful hearing all the presentations and comments. Can you please go to the next slide, please? So just reflecting on all that we've discussed, digital misinformation is becoming a very big issue. And what is WHO doing about this? So one of the things that we're doing, starting with family planning, and I think this really segues nicely from the previous comment about translating our evidence to plain language, is we're actually working on a toolkit and content repository, simplifying information from the medical eligibility criteria, from the handbooks, and from all these very scientific evidence-based resources, but trying to meet users, content creators, implementers to where they are, and being able to accelerate the process of creating content for digital spaces and not trying to leave that as a void, and also potentially using this as a platform for content moderation and new creation. If you just click again. So this is something that's going to be coming out soon. It's going to be a repository with messages that can be adapted. We as WHO know that we're very good at creating scientific content, but maybe not as great on doing the icing and, the resonance that's going to really actually stick with populations, the tailoring and all of that. So this is a starting point that implementers, creatives, social media influencers can use to then adapt to their local context. And as WHO, we have some initiatives that we're testing this through and also for broadly using. One is called FIDES. We're training networks of social media influencers to be able to more actively use WHO content. There's been collaborations that are being established with the tech industry, including TikTok, to see how can our content be more within the natural journeys that users have when they're getting content online. It's not going to be campaigns, but they're maybe getting it through a different variety of sources. And how can we make sure that WHO and validated health content is there? And then also just doing more social media listening. So this is actually being able to pick up the myths and misinformation a little bit faster and being able to be responsive to that. I really appreciated Innocent's comments about, the questions that come up. And we as WHO also want to make sure that we're being responsive to that. So we have a starting point within the repository that deals with, common myths and misinformation, but we actually would like to continuously crowdsource this so that when information comes up, we know exactly ways that we can respond and have that content ready. So I'll stop here. There'll be more soon coming up, and this is something that we'll be releasing in the next month or so, but just to kind of say that we are trying to also fill that space of getting content out there to tackle the misinformation and promote validated health content. Thank you.
Wonderful. Thank you so much, Tigest. And thank you to all of our presenters for that stimulating discussion, sharing your experience, sharing your reflections. There was a lot of engagement from our colleagues online. Thank you again for participating. We are just delighted to provide this space, as I mentioned, here at WHO, HRP. We are here to create spaces to have these difficult conversations. So please do stay tuned for the next session. As Tigest mentioned, we'll be featuring some of the tools that are being created and hope to have you join us at that time. So thank you again, everybody. Again, the session will be recorded and posted on the WHO HRP Media YouTube channel, and we hope to see you again next time. Thank you so much. Bye-bye.